Hello, sir.
Yes. Solunga.
Hello, sir.
Yes.
Yeah, Ankur.
Yeah, sir. Can we start, sir?
Yeah, you can
Yes,
open
please,
for the
please.
video.
Okay, no issue. Just give me next 1 minute. I'm processing it. Yes, sir. We are live. Over to you.
Yeah, thank you. Yes,
Yeah.
thank you, sir. Good doctors. On behalf of Alchem Laboratories, India's fifth largest pharmaceutical company, I'm Balaji, CSM for Alchem Aspiria Division. Take great pleasure in welcoming all the eminent doctors to the panel discussion. Doctor, today's panel discussion will be on titled Views on Vildagliptin. To partner with healthcare professionals, and we will continue to do so. To help us to navigate through the entire meeting, we have Prem Kumar sir, who will be our moderator for today's panel discussion. I take this opportunity to short introduction about our moderator, Dr. Prem Kumar sir. Dr. Prem Kumar sir is a senior consultant endocrinologist who is currently practicing at Diacare Clinic, Salem. Doctor has done his assistant professor. Doctor was in Venkateshwara College, Pondicherry, in the year 2007, and he worked in PIMS Hospital as assistant professor of medicine. And doctor is also he has worked as in Amrita Institute of Medical Sciences. Doctor has got credit of total 60 presentation in various medical forums, which has happened all over. And doctor is a active member of Endocrine Society of. He has individually co-organized 3 CMEs, which has happened in the last 1 year. Doctor is highly involved in research work. He is involved in endocrine research. He has got with credit close to 7 papers, which is in pipeline for publication. So with this short introduction, I once again welcome Prem sir for this meeting. Welcome, sir. Take this opportunity to welcome all the eminent panelists who have joined us for today's panel discussion. Doctor, let me give a short introduction of each and every single panelist. Doctor, let me take this opportunity to welcome first Dr. Vengo Jayaprasad sir. Dr. Vengo Jayaprasad sir is a senior consultant diabetologist who is currently practicing at Coimbatore. Doctor is the HOD of Coimbatore Medical College for the Department of Diabetology. We have with us Dr. Vengo sir. It's a great opportunity for us to have this Vengo sir for this meeting. Welcome Vengo sir for this meeting. Take this opportunity to welcome the next panelist, Dr. Pranesh sir. Dr. Pranesh sir is a senior consultant diabetologist and physician who is currently practicing at Coimbatore. Doctor is currently associated with his own clinic, Sai Diabetes and Medical Center at Coimbatore. Welcome Pranesh sir for this panel discussion. Take this opportunity to welcome the next panelist, Dr. Subhashni madam. Dr. Subhashni ma'am is a senior consultant diabetologist who is currently practicing at Salem. Doctor is currently associated with the Dania Heart and Diabetes Specialty Center, Salem. Welcome Subhashni ma'am for this panel discussion. Take this opportunity to welcome the next panelist, Dr. Sujay Nikhil sir. Dr. Sujay Nikhil sir is a consultant intervention cardiologist who is currently practicing at Pollachi, Coimbatore. Doctor is currently practicing in his own clinic as an independent consultant intervention cardiologist in Pollachi. Welcome Sujay sir for this panel discussion. So with this short introduction of panelists, let me hand over the session to our moderator, Dr. Prem sir. Sir, you can set the context for the meeting, sir. Over to you, sir.
Thank you, Mr. Balaji, and thanks, Alchem, for organizing this meeting. And this is a series of meeting which they have for the molecule they have vildagliptin, and I'm happy to see all the three people whom I know for a pretty long time, for the past 10 years, Dr. Pranesher, Dr. Vengo Jayaprasad, and Dr. Subhashini Devi, and all are my colleagues, and happy to be part in this forum. And to set the context right, today the agenda is to discuss on various aspects of vildagliptin. And vildagliptin, as you know, that it has gone off patent and is being increasingly used. If you take 2 years back, teneligliptin was widely prescribed, and vildagliptin is a molecule which is being widely prescribed. And to go back into vildagliptin, if you see the history, vildagliptin was the first gliptin to be identified by Wilhar. And after that, sitagliptin was identified, and it was in fact the first gliptin that was marketed and the first gliptin which we had in our country. And we have vast clinical experience in using this molecule. Before the advent of gliptins, we had only three molecules. We had the sulfonylurea, we had metformin, and we had pioglitazone, and we also had acarbose. But we had a lot of shortfalls in managing diabetes with respect to the quality of life, the hypoglycemias, the weight gain. And once this molecule was available, we took up this molecule. Many people got benefited. The idea of aim of achieving A1C less than 7 was fulfilled with this molecule without any hypoglycemia. Before that, 3 molecules we had used, A1C not achieved, we had to go for insulin. So it was very helpful. And achieving A1C from 7.5 to 6.5 became reality with this molecule without hypoglycemia and weight gain. And these were the characteristics of the molecules. So less hypoglycemia, less weight gain. And the molecule doesn't need any dose modification frequently, and less monitoring also. So many advantages with this molecule, could be used in a wide range of people with less contraindications. And though this molecule had very good properties in managing various people with diabetes with various issues, cost was a really big issue. Now that has been taken off. We are using it in a very broad group of patients. And a lot of details also had come recently. The publication on initial combination therapy with metformin, which really threw light into the way which we manage, how we manage diabetes. And we'll discuss all this in this coming, in this forum. So we have 3 eminent people in their own field, and we have one more doctor who will be joining now. And we'll have we'll pose one question to each of them. And the hot topic now is yearly intensive therapy with combination. There is a trial called as Verified trial, which had been published a few years back, and which actually changed the guidelines of managing. Initially, it was we start with metformin, you increase the dose, wait for 3 months, A1C not achieved, go for the next drug. So we didn't have any evidence to combine 2 particular drugs with that initial drug. Only thing was, if the A1C is more than 1.5% from the target A1C of the patient, then we can go for initial combination therapy. So the guidelines were very strict. So we couldn't give good control at the earliest to many of our patients with diabetes. So diabetes being a progressive disease, the one particular drug will not be effective for a long period of time. So what we call as glycemic durability. And we also know if you treat diabetes initially intensively, and whatever A1C we achieve in the initial 1 to 2 years of diagnosis of diabetes will have a long-term impact on the outcome, particularly the cardiovascular disease. So diabetes being a progressive disease, and now that Verified trial being published, which throws more light into using this particular drug, vildagliptin plus metformin as a fixed dose combination, as soon as diabetes is diagnosed. I will request Vengo Jayaprasad to give his view. How do you take this results of the Verified trial? And I would also request you to elaborate on the Verified trial to the benefit of the people who doesn't know about this particular trial. Over to you, sir.
At the outset, I'd like to thank you for giving me this opportunity, and very good evening to all of you. I apologize for not switching on my video, because switching on my video brings down my signal relay. So going to the question now. See, generally in our country, we see that at presentation itself, the patient has a HbA1c more than like the levels where we can use only lifestyle modification or metformin. So number one, so we have to start a drug with combination, which has a combination of a combination of drug or two drugs at least at the onset as per the guidelines even. So now we did not have enough evidences for that. But then once we had this verified trial, we found that adding metformin with a vildagliptin was the best choice among all the other oral anti-hyperglycemic drugs. So this verified trial gave us an additional input to this UKPDS diabetes study, which showed us that by around 3 years of diagnosis, approximately 50% of the patients needed an additional drug, and by around 9 years, 75% of the patient needed an additional drug. So now verified trial is one of the first studies to show that the long-term benefits and the glycemic durability of an early combination treatment strategy with vildagliptin and metformin compared with current standard of care late combination strategy in patients with newly diagnosed type 2 diabetes was there. So early combination of treatment significantly reduced the probability of initial treatment failure, the time to the second treatment failure, and the time to treatment failure compared with monotherapy. So all these things were the findings from the verified trial. So naturally, we are in a position where we need to start a combination therapy. And this verified trial gives us an idea that vildagliptin plus metformin could be the drug of choice when we use a combination drug at the onset of diabetes mellitus.
So what dose do you start, sir? You start with 5,500 twice daily, or you go with 1 gram twice daily?
5,500 twice daily, sir.
So would you like to adjust it to 50 plus 50 per 1 gram twice daily?
Yes, we always have an option of increasing from 5,500 to 51 gram twice daily. So like as the duration goes by, and then if the patient is not maintaining blood sugars with 5,500, we have an option of going from 5,500 to 51 gram before adding another drug.
So do you see any hypoglycemia? Because our people are always ask the side effect before even knowing what drugs we are prescribing. And regarding the side effects, look at A1C, what they have taken from 6.5 to 7.5 at the time of diagnosis. So, and they didn't show much hypoglycemia compared to metformin alone. If you look at the trial, the adverse event profile. So, in your practice, do you see any hypoglycemia when you use this drug in A1C less than?
As such, see, like we get patients with symptoms of hypoglycemia, but we don't have proper documentation of hypoglycemia with this molecule. Because when we have a patient who comes to us with a HbA1c of 9 plus or even 8.5 plus, and the blood sugars drop down, they definitely can have pseudo-hypoglycemic symptoms.
Exactly.
So they do definitely have symptoms of hypoglycemia. But then if we ask them to come with the proper documentation, it is not there. So we reassure them and send them off. So actual hypoglycemia, either nocturnal severe or general hypoglycemia, I have not seen unto date.
Yes, thank you. Thanks for giving your insight on that. It was very useful. And this yearly combination therapy is new evidence to take the yearly intensive treatment. Initially, it applies only for insulin because whomever you give, they get a normal glucose level. But when you go for a OHA, very few percentage of people get a A1C, the desired target. But in our practice, we see when you start this molecule and tell them to come after 2 weeks, the glucose level comes down. And hyperglycemia doesn't actually happen. The glucose level will be between 90 to 130 and postprandial will be less than 180 for a prolonged period of time. And as you rightly said, it prevents the secondary treatment failure to vildagliptin and also treatment failure to metformin. So that is the boon, because in this particular trial, if you see, when they compare it with metformin, Yearly metformin treatment failure was more actually. In those where it was used, it doesn't happen. And secondary treatment failure to vildagliptin also happens. So basically what we do is we preserve the beta cells by intensely controlling the glucose level, reducing the oxidative stress under the glucotoxicity. And there was one more paper following the verified trial which showed that HOMA-B is preserved relatively better in the combination group compared to the metformin group alone. So that was a great, it is reassuring. So say that if you treat intensively, in fact, you protect the beta cells and the durability of control will be very good. Thank you, sir. And dear friends, that was the insight on verified trial. And now vildagliptin.
Added on this, to add on this, the early intensification definitely it improves the metabolic memory, and there will be a legacy effect too. So that there may be a reduction of severe risk also.
Definitely. Okay. First 1 year, how you treat determines the CV outcome after 5 to 7 years. So that we can do. Initially, we had to wait for 3 months, then slowly titrate. That lag will be prevented.
That paradigm has been shifted now.
Yes, that's a nice thing.
I have a small doubt. I'm outside the diabetology circle, so my doubts will seem very trivial and very small, but I have a doubt. I think I should express it out.
This is a forum text.
Yes. So the HbA1c, does it decide whether we start with the Vilda 50 and 500 metformin, or like if the HbA1c is above a certain percentage, do we start directly with the 1000 milligrams of metformin BD as a combination? Is there any evidence supporting that for an aggressive form of therapy?
Yes, that's what. The verified trial which we are discussing is a trial was a first of its kind designed to look into this factor of yearly intensive treatment with a oral drug. Initially, the guidelines said we have to start metformin, then we have to give the second drug, slowly increase the dose. And the verified trial included people with HbA1c between 6.5 and 7.5 and gave 2 drugs to its fullest dose. If they develop intolerance to metformin, they reduce the dose and slowly they uptitrate it. And that's how they did it. So it definitely showed benefit over metformin monotherapy, and there was prolonged good control, and the treatment failure didn't happen, and beta cells are preserved.
Okay. Thank you.
Thank you. So thank you, sir, for the question too. And I encourage other audience to intervene in between and this one involved in the discussions. And that was a nice question. And so, friends, we have been using this particular molecule for a prolonged period of time. And if you look at patients with diabetes, every patient with diabetes is different. With the same A1C, they behave different to one particular drug. Some people will respond well to glimepiride. Some people will respond well to DP4 inhibitor. Some will respond to glitazones. So the phenotypic presentations of the diabetes is different. So obese diabetes, lean diabetes. So if we look at the various drug profile, what they have after metformin, some people will be on glimepiride, some people will be on DP4 inhibitor, some people will be on glitazone, some people will be on acarbose. So some people will be straight away started on insulin because of the magnitude of hyperglycemia. These are the various patient profiles. So when one patient is not controlled with monotherapy, we go for a second add-on therapy. When patient is on 2-drug therapy, we go on for a third add-on therapy. So we have this DP4 molecule for more than 10 years with us with a lot of evidences. So what will be the A1C reduction when it is added on to metformin, when added on to metformin plus sulfonylurea, added on to glitazones, added on to insulin. So the efficacy still remains for vildagliptin significantly. So I like to ask Dr. Pranesh sir to highlight on the efficacy of vildagliptin when used on combination therapy with sulfonylurea, with insulin, with glitazones, and what do you see the effect and how beneficial it is as a second add-on therapy and third add-on therapy and as an add-on therapy to insulin and as a monotherapy.
First of all, I would like to thank the Alkem people for organizing this virtual seminar and calling for me. And as you said, the combination therapy, definitely vildagliptin can be given with any other combination, like insulin in Galapagos study. If you see, there is a good reduction of both fasting and postprandial sugar levels in Galapagos study. In the earlier study 10 years back, it was showing a very good result. At the same time, with when the combination, the ideal add-on after the sulfonylurea and metformin failure also, vildagliptin shows very good results because of the around 84% of DP4 inhibition has been there for 24 hours when compared to the other gliptins. So that's why vildagliptin has got a good role in combination therapy in where so many other add-on therapy can be given, and a very good reduction of HbA1c can be seen in a trial like Victory study and other studies also in the initial study. So this all shows a good reduction of HbA1c within 12 weeks and even 24 weeks, and I think. So that is my distinct.
And do you see, sir, with added on to insulin, how is it efficacious, and does it lead to any hypoglycemia more?
No, usually now with a good basal insulin, what we have a second generation and first generation insulin, basal insulin, you don't have any absolute. I don't feel any hypoglycemic symptoms per se in my patients. Those who are on insulin, basal insulin, along with the vildagliptin and metformin. What usually I prefer with this combination beautifully, and a very good reduction of both fasting and postprandial levels. What I have seen in my experience.
So that's the advantage of giving it twice daily. And so there's a 24-hour action.
And compared to the insulin sector GOGs, this combination is very good.
Yes. So initially, sulfonylureas may give a good control, but if you look at the long term, the efficacy is comparable. And because it suppresses the glucagon, fasting sugar also gets controlled. And so vildagliptin, as you rightly said, can be given as a first add-on drug, a second add-on drug, and in some people we also see metformin intolerance. And when insulin sensitivity is not started, we have to give the other insulin sensitizer, which is glitazone. Glitazone has many contraindications, especially in elderly with CAD, postmenopausal women. Again, we can start this as a monotherapy molecule. Efficacy, what we see is same as a monotherapy, as an add-on therapy, a second add-on therapy. Nice, sir. So as you rightly said, this particular molecule finds a place at various stages of diabetes, some insulin or oral drugs. So that's good, sir. So we see that long-standing diabetes and in elderly patients with diabetes, there is a reduction in the GFR. And poorly controlled diabetes for the initial 5 to 7 years, leads to microalbuminuria and then macroalbuminuria. And when it comes to anti-diabetic drugs, a lot of concerns are there. And a lot of precautions we have to take, depending on the population rate. And so if you look at the metformin, definitely when the GFR gets below 45, you have to reduce the dose. You have to stop if it is less. And similarly, the contraindication exists for glimepiride and all the DP4. If you look at the DP4 inhibitors, they differ in their pharmacokinetic action. So though they are same in efficacy, they differ by pharmacokinetic action. And I would like to ask Dr. Subhashini Devi how to use this particular molecule wisely, vildagliptin, with respect to the GFR. And also elderly patients, and this particular molecule who have a concern of low GFR, how can we safely use? Does it lead to any reduction in the efficacy? Does it lead to more hypoglycemia? And does it become toxic in a patient with CKD? How to judiciously use it? How to titrate the dose?
Thank you, Alcom, for the opportunity, and nice to see you all after a long time. And I'm very sorry to interrupt. I can hear your own chanting, which is a little louder than.
I don't know where it comes from. What's the Yes.
Okay.
I would stop. I think in my clinic it wasn't.
Sorry.
Okay, it's okay. It's okay.
So in elderly patients like with who are already having renal insufficiency, we generally prefer insulin over any other drug for better glycemic control. But with insulin, there is always a fear of hypoglycemia in particularly elderly patients more than 70 years. So with DPP4 inhibitors, we have a right to use them in elderly patients with a mild eGFR. We can use the drug without any dose reduction, and with the patients who are having less than 60 ml, we can reduce the dose and use. And vildagliptin has been used in many studies, including the elderly patients, And it has been seen that there is less evidence of hypoglycemia, and there is also an improvement in the renal function with days. And along with insulin, if needed, it plays a better role in getting a good glycemic control. So vildagliptin is a drug of choice in patients with renal impairment, in particularly in elderly patients, because insulin, we have a fear of hypoglycemia, and SGLT2 inhibitors also are not very much recommended in elderly patients. So vildagliptin can be used very well in the elderly patients for a better glycemic control, even though they have a renal impairment.
Regarding the dose modification according to GFR,
yeah, like when the GFR is more than 60 ml, we need not reduce the dose. We can continue with 100 milligram per day. But with the less than 60 milligram, we can reduce it to 50 milligram per day, and we can avoid if it is less than 30 milligram per day. Sorry, 30 ml per day.
That's true. That's true. So in a patient who undergoes dialysis, it can be given after the thing, or if a patient is having good control, I think it can be continued. And but as you rightly said, ESRD, it's better to use a drug, say, which is well established, which can be none other than insulin. Yes. And as you rightly said, in elderly people more than 70 years, this particular drug can be used without any monitoring, and the hypoglycemia risk is less, and efficacy is not compromised in elderly. Yes. Thank you. So anything, anybody, other people, anybody you want to add? Your experiences? Do you use it in CKD patient, dialysis patient? Sir, Pranesh, sir? Okay.
No,
So
I don't
think
have an idea. In ESRD patient and less than 30, I've never used.
So actually, that will be a more prudent way. Though it can be the medical case, it can be used. It will be better to give it. That's right. Thank you. Thank you. So, so we have looked at the complication. One is the microvascular complication. The other complication what we have is macrovascular complication. The vascular effects of diabetes. Diabetes is a vascular disease, and prolonged poor control over a period of 5 to 7 years definitely causes changes in the vessel wall and manifest as MI or a stroke or a peripheral artery disease and so on, particularly when combined with hypertension. More than 50% of the people with diabetes die because of heart disease, and it can be, it is collectively called as ASCVD. And the burden of ASCVD is increasing, and our people are getting affected at an early age, younger age, because maybe we are diagnosing diabetes much later, and that's why the complication became irreversible by the time they get diagnosed. So we have with us Dr. Nikhil, who is a cardiologist from Pollachi. Welcome, sir. And Doctor, I would like to ask your opinion regarding your usage of gliptins, particularly vildagliptin, in a patient who has got a underlying CAD, especially in an elderly patient who has got multiple comorbidities, and where hypoglycemia, if it happens, can precipitate a cardiac event. How do you see DP4 inhibitors with respect to vildagliptin as a choice in patients with CAD, and also in elderly patient with multiple comorbidities, the occurrence of hypoglycemia and the safety of DP4 inhibitors? What do you say?
Okay, so most of the patients diabetic, especially the elder people, I think around 40 to 50% of them are the non-diagnosed diabetics earlier on. They present with an MI, and then we do the routine test. The HbA1c is around 10, 11, and then we tell them that they reflect the same thing, or there'll be multiple lesions and all that. My first choice, at least in the past 1.5 years, has been a combination of vildagliptin or a teneligliptin with metformin. And I was under the impression that you need to start with a higher therapy. So I used to start with 1,000 milligrams of metformin BD initially, if his renal function was all right. And they usually get discharged within 3 or 4 days. And by then, you know how well or how not well the patient is responding to your therapy. Just oral therapy is enough, or you need to supplement it with some insulin or something. So most of the, I think at least around 70 to 80% of the patients, they respond very well. Initially, the admission sugars would be randoms would be around 300, 350. The fasting would be around 250, 300 sometimes. And on the day of discharge, we do a repeat fasting sugars and a postprandial. We see a good drop in sugars. If the patient has come in with 300, they would be going home with some 170 or 160 fasting. and they would have the consequent follow-ups. You see, they respond well, and the HbA1c ultimately drops faster. As I said, in the past 1.5 years, I've seen the HbA1c drop is much more significant compared to other combinations such as glimepiride, metformin, or you supplement it with insulin or just insulin alone. Some patients are really, I have seen some groups which are weirdly, they request only insulin. They don't want any oral drugs. They say, we want only insulin. Even those people, the HbA1c, it is, or rather the titration of the insulin is very difficult when, at least for me, because we see patients 3 months and once in 6 months, once they've settled down with everything. So I think the oral usage of vildagliptin has helped me to keep the diabetes much easier in check. And renal deficiency, really at the last milliliter. But if the creatinine, if the urine output is fine and it's showing signs of CKD, but the output is fine, I usually continue them with vildagliptin. And if the creatinine is on the higher side, maybe 2.5, then I start calculating the GFR. And definitely, as Madam said, if it is between 30 to 50, I drop it down to half dosage. And less than 30, I don't think we keep them here. We refer them for further higher center referral for getting a nephrologist opinion also, because ultimately we'll have to end up doing a coronary angiogram, which will need a nephrologist clearance. So as Madam said, I've dropped down the doses from 30 to 50. I've dropped it to half what we give. And definitely they have been tolerating it well. As far as the IP admissions have been concerned, the hypoglycemic effects are very, very negligible. And so I think they have been tolerated well, and they're really very useful in IP as well as OP from my practice.
So because you are from cardiology, I would like to, this is the right point to ask you too. There is a differentiation between the widely available gliptin, teneligliptin and vildagliptin. Teneligliptin, when used at a dose of 40 mg, there is a significant increase in the QTC. And many drugs have QTC prolongation. And how much impact it has in your practice? How much seriously you take this particular issue, though we are not using it at 40 mg? And yes.
So QTC prolongation, even I was reading about it before I start prescribing a drug. I read about it, mainly the adverse effects, to see what we have to watch out for. And the QTC prolongation was on the top of my mind when I started teneligliptin. And I'm not, fortunately, I've not had so many patients with prolonged QTC that I had to change back to from teneligliptin to something else. I would say roughly around 30% of the patients developed some form of QTC prolongation. But I usually try to persist with the drug and see if it settles, because the QTC prolongation could be secondary to the myocardial infarction. It could have conduction disturbances. So we maintain the same dosage for maybe 24 hours and see if there's any change in, or whatever it is, better for the better or for the bad, whether there's any change in the ECG. And usually, again, in that 30%, maybe around another 10-20% settle down, and they have normal QTC. So I would say let us not worry too much about it, but if the patient is being symptomatic, definitely there is one thing to look into it. But I wouldn't go for so far as to say huge. I need to have. As I said, my patients do have it, but not a big threat.
So, but in the diabetes, if we are using amitriptyline very widely, there are many other drugs which also prolong the QTC. Actually, it becomes, as you rightly said, multiple other drugs could lead to the cardiac disease itself can lead to QTC. And this becomes a point of debate or a discussion point when such issues get discussed. Thanks for giving your views.
Yeah. Thank you.
So, difference, we have been using this molecule. It's off patent now. And when it comes to managing diabetes in India, where the burden is huge, cost pharmacoeconomics becomes a huge issue, which actually determines what drug we are writing. And we can give the best drug to the patient, but if the patient is not able to afford them, that becomes a burden to the patient, and the diabetes control may not be assured. So this was the initial thing. So you wanted to use a drug which gives a good 24 hours control, and but at the same time it should be less costly. Now with the off patency of vildagliptin, now there is a tsunami of vildagliptin brands and other places. And the good thing that had happened is from 40 rupees, the 30 rupees, the drug has come down to 10 rupees and below 10 rupees. So that puts the daily cost of metformin and vildagliptin therapy to 10 to 12 rupees per day. And that too in combination with metformin cost is not taken into account. So we have this particular molecule, which gives a wonderful control for a longer duration of time, now available at a cheaper cost. And now with this aspect, I would like to know the opinion from all the panelists. How do you see this vildagliptin going off patent, and how it has changed your practice? And I also take your comments on whether the quality has been compromised or not. What do you see the efficacy? Has it reduced or not? I invite all the panelists to give their valuable opinion.
Yeah. Can I start off?
Yes, Sarvendra sir, please.
So, absolutely, it is a welcome that vildagliptin has gone off patent. Because before vildagliptin went off patent, we had only one another molecule, that was teneligliptin, which was a cheap molecule. But then it was a molecule which was not a well-studied molecule. Whenever a DPP-4 molecule was needed, we had to go in for teneligliptin instead of vildagliptin, because in India, we are more price-sensitive market rather than the evidence-based market. But the second question, as you asked, Prem, is the issue of quality. So whether all the molecules are like the originator or not. We believe they are like originators, but in practice, we see that it is not so. So it is purely dependent upon our clinical acumen and varying other studies or varying other recommendations by the DCGI or any other comparative studies that we will have to depend and choose the molecule accordingly. So I think that ends my opinion.
Thank you for the valuable opinion, sir. Ganesh sir, your opinion?
Sir, in my opinion, I think it has been increased the prescription of vildagliptin after the off patent, definitely. So we used to hesitate earlier in some of the patients. It all depends on the where you practice at the area. So the middle and upper middle class people, those who are affordable for galvosmet, they used to prescribe. But nowadays, definitely it has been increased without any hesitation. We can add this molecule definitely to any other drugs, and that is my opinion. At the same time, you should be little careful while using it along with sulfonylureas. That's all.
Definitely, definitely. Hypoglycemia gets magnified when it's used.
Yeah.
Subhashini ma'am, what's your in the practice? Do you see has your prescription increased after the off patency?
Definitely, like now it has become a common man's drug. Like earlier we could prescribe only for affordable patients. So now we are able to prescribe more, but we have to choose the right patients and the right brand, which we feel after like nearly last 1 year, more than 1 year, we are able to get the low price brands. So we can judge which brand is efficacious, and we can choose the right brand, and we can prescribe for the patients who are in need of vildagliptin and who cannot afford for a brand like originator's brand.
Dr. Nikhil, so has your prescription increased with this off patency? How do you see
Yes,
this
definitely.
advancement?
Because once the patent goes up, the price drops, and as you said, the prices come down from almost 40 to nearly 15 to 10 rupees. And whenever we write a prescription, especially when we discharge a patient who's been newly started on a vildagliptin, and he's going home not just with vildagliptin but with a huge list of other drugs which he has to take, maybe another 3 or 4 drugs which are really necessary for his cardiac well-being. And the change, or the drop in the price has helped us to add this drug more frequently. So maybe monthly prescription for him, the price reduces from maybe around 1,000 to 1,500. The difference is there for him. So that has definitely helped us to increase. And as Sir, Madam, everybody is saying, the drop in the price, again, we have to choose the molecule what we are writing. There are some companies who give really ridiculously low priced molecules, which makes you question the authenticity. But generally, I think what we choose, usually what we keep and what we choose will be a good molecule. And yeah, I think it has really helped the prescriptions to increase.
So thanks for all your opinion. And now this vildagliptin molecule once daily preparation has come. Though I have not taken up this molecule, I just went through the literature, and Novartis before launching itself, they had studied this once daily preparation, and And they also had this, but since they had to give a 24-hour efficacy, it was used. Now the innovator also has brought once daily preparation, and other Indian companies also had brought this molecule. But I don't have any this one to it. I have not used it. So I asked the panelists their experience and have you taken up this molecule, and what is the efficacy you see with this particular molecule, once daily preparation. Anybody, sir? Finish, sir?
I have been prescribing few patients with once daily, and I particularly use in patients who are having high fasting sugars. Like even if the 50 milligram is not able to reduce, and if I increase to 100 milligram OD, I could see a better reduction in the fasting blood sugars. So I have been already using this once daily 100 milligram preparation, and I feel like fasting sugars are getting better with a night dose of once daily 100 milligram compared to only 50 milligram BD.
So recently, yeah, pill burden, you can reduce the pill burden, but recently I've taken up this product, but I'm watching, and one of the, for some of the few patients are on OD, but we have to see whether what efficacy will be there, how the fasting and post-prandial will reduce with this. We have to see in different types of patients I have put with insulin, without insulin, and with some other drugs I have put, but we have to see and wait and watch.
Any which way, we are going to use this molecule with metformin, which needs twice a day dosing at least. So when you are going to use metformin twice a day, why not we use 50 plus 500 twice a day? Instead of going with vildagliptin 100 OD and metformin twice or thrice a day, that will be actually 3 pills a day. So if you have a combination of 50, 500, 50, 500, that will be only 2 pills a day, number one. And number two, Novartis actually came up with this 100 milligrams dosage earlier, and it went on with the studies. But it was found that it increased the liver cell, the liver hepatic derangement or enzyme derangement was found. And the study was stopped in between and it was taken back. So without enough studies backing up 100 OD, it is better not to start off. Unless otherwise, it is mandatory for the patient, or it is a request from the patient to reduce the pill burden.
So at least for the hepatic safety, the later data came actually on vildagliptin. Now, if you look at all the gliptins, whenever the SGOT, SGPT is more than 3 times elevated, in all the gliptins are not safe. Though we say certain gliptins are this is predominantly excreted to particular route, it is not safe. And liver enzyme elevation was a concern initially, and further studies actually had not silenced it because there's not much of safety issues with this particular molecules. And as you rightly said, that when it is used with metformin, there is an superadded effect. It's not just additive; it's more than that. So if 1 plus 1 is equal to 2, when this particular 2 drugs are used, it's 2.5. So you get further elevation because when used along with metformin, there is further increase in GLP-1 level. So super additive benefit is there, and this is an ideal partner for both the drugs. And so that is there. So as you rightly said, more data has to be published on that, then one can take up this particular molecule. Yes, so I think we had spent good amount of time, and I request the audience, if they have any questions, they can unmute and ask in this particular forum.
Sir,
question chat box.
Prem sir, there was only one query on once daily formulation. I think that is addressed by the panelists.
Yes.
I think all other points were completely covered up by all the panelists, so that's why there is no more queries on this. Only one query there.
Okay. So I think we had a good discussion, and I thank all the panelists for spending your valuable time and sharing your experiences and knowledge and your views on that. I thank Vengo sir, Dr. Pranesh, Dr. Subhashini ma'am, and Dr. Nikhil whom I'm meeting for the first time. Welcome, sir. So hope we'll see you multiple times hereafter. And so I think we had good discussion, and I thank all the attendees for patiently waiting us and viewing our discussion and asking the questions. I hand over the session now to the organizers to continue.
Thank you, sir. Thank you. Sir, take this opportunity to thank all the panelists and moderator Prem sir for giving us this opportunity and moderating the panel discussion today. I thank all the eminent panelists who had given this opportunity and shared your clinical experience on vildagliptin, which will be more useful for all the delegates who participated today. So I'd like to thank all the at this juncture, I'd like to thank all the doctors and paramedicals who contributed immensely to keeping us all safe and healthy in these challenging times. So we at Alkem Laboratories will continue to serve doctors and patients by making our products available, especially our chronic brands, Gluvilda and Jupiros and Volcom. Thank you, sir. Thanks once again. Good night, doctors.
Thank you.
Thank you.
Thank you. Thank you. Thank you.
Thank you.
Thank you, ma'am.